Okay, welcome everybody. We're here today presenting on today's webinar, Emerging Topics in the COVID-19 Pandemic, the latest in science and community-based practices for Native Americans. We are glad you're all able to be here today, and I would like to open us up with a prayer. So feel free to bow your heads. Dear Heavenly Father, I thank you for this beautiful day that you have given us. I thank you for bringing us here together and for giving us the opportunity to have this discussion on today's topics and being able to gather and give us the bond us together with this information that we are about to receive. And also thank you for giving us the opportunity to be there for our communities and to support them throughout this ongoing COVID-19 pandemic. In Jesus' name we pray, amen. I would also like to get started by introducing our speaker, Dr. Laura Hammitt. Dr. Laura Hammitt is the Director of Infectious Disease Programs at the Center for American Indian Health and an Associate Professor at the Johns Hopkins Bloomberg School of Public Health. Throughout the COVID-19 pandemic, Dr. Hammitt has worked closely with tribal partners to strengthen prevention efforts, including leading the ongoing clinical trials for the Pfizer COVID-19 vaccine and booster study on the Navajo Nation and in the White Mountain Apache tribal communities. Thank you so much, Dr. Hammitt, for joining us today, and I will pass it on to you.
Thanks so much, Olivia, and thank you everyone for joining today. It's really my honor to be with everyone today. You guys are on the front lines and doing such great work, and I'm happy to be here to provide a little bit of an update. I'm going to go ahead and start to share my screen. And Anna, can you let me know, is that the right view for everyone? Okay, super. Thanks so much. So we're going to talk this morning about an update on the COVID-19 variants and breakthrough cases and booster shots. And I wanted just to start by giving everybody an update on where we are now. We've all been dealing with this pandemic for over a year and a half. And I think it's important to keep sight of just, how much of an impact this has had, not only on our, individual lives and families, but throughout our country and throughout the world. In fact, over 200 million cases of COVID-19 have occurred globally, and there have been over 4.5 million deaths. Here in the United States, you can see the trends in daily cases on this graph, and we have in the US alone, over 40 million cases of COVID-19 disease and 650,000 deaths. And you can see this graph goes up till just last week, and you can see where we're now grappling with this third wave of COVID-19 disease. This slide shows what's happening in terms of cases by rate and ethnicity. The yellow line represents the American Indian Alaska Native population. And I know this is not showing you anything that you don't personally know from your own lived experience, but the Native American population in the United States has been among the hardest hit in terms of this pandemic. And you can see here we are over on the right-hand side where the most recent cases are occurring. And again, we're still struggling with high rates of disease. This is another way of looking at the available data. This is not focused on cases, but actually on COVID-19 hospitalization trends. And what you see in the top graph is that hospitalization rates over time by age group. And the line with the highest rate of disease is this sort of reddish line here, which are people 65 years of age and older. So the highest rates of hospitalization throughout the pandemic have really been among people 65 and older. We all know this has really hit elders hard. And then you can see in the lower colored lines here, I do want to highlight that this is in the sort of yellow color, that's children 0 to 4 years of age. And in the gray, it's children 5 to 17 years of age. And all along the pandemic, you can see fairly low numbers of cases in kids. But if we just focus in on those two youngest age groups, you can see that here now towards the end of August, we're starting to see that the rate in children is, as high as it's been ever during the pandemic at this point. And of course, kids under 12 are still not able to get vaccinated. So just a brief check-in on where we are now. The Native American populations are once again experiencing high case rates compared to other race and ethnic groups. Some communities are experiencing large surges, even larger than we saw last winter, with critical ICU bed shortages and high test positivity rates. And the current surge is also causing an increase in cases among children and young adults. And I think everyone knows that, right now this current surge is being driven by a specific variant. And so I want to take a minute just to discuss variants and remind ourselves what variants are. In fact, all viruses, including SARS-CoV-2, the virus that causes COVID-19, all viruses change over time. And when a virus infects a person, it makes copies of itself, or it replicates. But when viruses make copies of themselves, they don't always make perfect copies. Sometimes the copies have small mistakes that are called mutations. And those changes can result in new viral variants. Most of the time, this is happening on an ongoing basis, and there have been thousands of variants that have emerged over the course of this pandemic. Most of the time, this doesn't result in anything that's harmful, but some of the and most of the mistakes actually make the virus, can make the virus less harmful to humans. So it's not even something that's capable of infecting humans. But sometimes the mistakes lead to what we call a gain of function, meaning the virus can be more easily transmitted. It can become better at evading immunity, or it can become capable of causing more severe disease. This is another way of sort of thinking about that same concept. Over on the left-hand side, you really see the virus spreading from person to person to person. And the more a virus spreads, the more chance it has to mutate. Every time it replicates, it has a chance that there's a chance that that replication process will introduce mistakes. And over time, lots of mistakes have been introduced into coronavirus. So far, like we've said, that hasn't had a huge impact, but some mutations lead to new variants that can help the virus. And those variants can become the dominant type. And you can see a sort of cartoon here of a variant developing where there's a change, a mutation that's occurred when the virus sort of replicates itself. It has this change here that can lead to potentially a more harmful variant. If you think about a variant, if you think about a virus growing like a tree, then all of the branches of the tree is slightly different than another branch. And by comparing the branches, scientists label them according to their differences. And these differences can be studied over the course of the pandemic. When a variant comes along that has a so-called gain of function, those can be labeled as variants of concern. And you've probably heard that term. That's a term that the CDC uses and the World Health Organization uses to describe strains of the virus that have been demonstrated to have changes that confer some public health significance, either an increase in transmissibility, an increase in severity, or a change in the clinical presentation, or a decrease in the effectiveness of our public health and social measures that we use to combat the virus, or a decrease in the effectiveness of the available diagnostics, vaccines, and therapeutics like monoclonal antibodies that we use to treat people. When variants, were first being labeled, variants can emerge. The same variant, the same exact mutation can actually happen in multiple places at the same, multiple places around the world at the same time. But when we first started labeling these different variants, they were often being referred to by the first place that the strain was detected. To avoid stigmatization, the WHO adopted a naming system for the variants. And you can see that here where we have the alpha variant, which is the lineage that's shown here. And what we learned about the alpha variant, that first variant of concern that we identified that had an increase in transmissibility, abbreviated T here, and an increase in severity. The other variants of concern designated by the WHO and by the CDC are the beta variant, the gamma variant, and of course now the Delta variant that we all know is driving the current surge. And this Delta variant has all of these different attributes: an increase in transmissibility, an increase in severity, decreased effectiveness of monoclonal antibodies, and some decreased effectiveness of vaccines. And we'll talk a little bit more about this variant in just a few minutes. But I wanted to help everybody to understand that naming system that we have in place. In addition to variants of concern, other variants have been labeled as variants of interest. These are strains that contain changes that are predicted to affect one of those characteristics, either the transmissibility, the disease severity, the effectiveness of the diagnostics, vaccines, or therapeutics. And this is something that's been identified that can cause significant community transmission and that may represent an emerging threat. So right now, the WHO has a number of different variants of interest that have been identified. Not all of them have actually been labeled as variants of interest by the CDC here in the United States. And that's largely related to the fact that even though we may have those strains in the United States, they don't seem to be having, gotten much of a foothold at this point. And so they're not currently considered by the CDC to be variants of interest. Circling back now to the Delta variant, which is what I mentioned is driving the current surge. This is the most contagious version of the coronavirus that we know of worldwide. It grows much more quickly inside of people's respiratory tracts and noses to levels that are 1,000 times higher than we were seeing with earlier strains. And I think this is what really, we have to just change how we're thinking about the pandemic because of just how contagious this particular variant is. Because it grows to such high levels in the respiratory tract, it spreads about 2 to 3 times faster than the original version of the virus. And it's really just dominating the outbreak in the United States right now, responsible for over 95% of COVID cases here. And you can see on this graphic, if we think about the original COVID strain, somebody with COVID-19, being predicted to infect 2 individuals with the Delta variant, if people are unvaccinated, somebody who's infected may spread that to 4 or 6 people. So it's much, much more contagious than we were seeing with earlier strains. So that's the first point that's highlighted on the top of this slide. The second point is that not only is Delta causing more cases, but data suggests that Delta may also be causing more severe illness than in previous variants. And in particular, unvaccinated people are at very high risk of getting sick from Delta. The risk for developing serious illness requiring hospitalization remains very low in those who are fully vaccinated. Like I said, most people who are fully vaccinated with 2 shots of Moderna or Pfizer or 1 shot of Johnson & Johnson are well protected against severe disease from Delta, but vaccinated people can still get infected. And that's what I think everybody's probably heard this term breakthrough cases. That's what we're talking about with breakthrough cases. It's when somebody who's fully vaccinated against COVID-19 gets infected. These remain relatively uncommon. And fortunately, most infections in vaccinated people aren't causing severe disease because the vaccines provided some degree of protection. For most vaccinated people, their immune system, because it's been primed by the vaccine, it can spring into action and it can prevent them from getting very sick. That's not always the case. In some people, the virus does gain a foothold and replicates and can cause symptomatic disease, a true breakthrough case. There are a number of different factors that influence whether this happens. It can be the amount of virus that somebody is exposed to. If you sort of have a direct inoculation with a very large amount of virus, that can overwhelm our immune system and be hard to fight off. The amount of antibodies that we have from the vaccine may not be enough to fight off the virus, or the strain of the virus that a vaccinated person gets exposed to may not be as something that our antibodies can fight off as well. So there are different factors that contribute to whether or not a vaccinated person may get a breakthrough case. But what we know is that vaccines still work very well to protect against severe outcomes. The vast majority of hospitalizations and deaths are among unvaccinated individuals, and only a small percentage of COVID-19 hospitalizations and deaths occur in vaccinated people. If a vaccinated person does get infected, they can spread the Delta variant. And I think this is an important fact that we've realized, just recently with this phase of the pandemic and learning more information about Delta and how it spreads, is that vaccinated people can spread the virus if they get infected. They tend to be contagious for a shorter period of time. So the vaccine does provide that protection. The antibodies sort of kick in and they're contagious for a shorter period of time. But vaccinated people can spread the virus. And I think this means we really need everyone, including vaccinated people, to wear their masks, to stay home when they're sick, to avoid large gatherings, and to get tested if they have symptoms. I think, along those lines, we all want to make sure that we're doing everything we can to protect ourselves, to protect elders, and to protect our children from Delta and from other variants. And I think I just want to reiterate that vaccine remains the most effective tool that we have. So encouraging everybody to get vaccinated if they're eligible. The vaccines protect people from getting infected most of the time, and they really protect people from getting severely ill. If somebody does have a breakthrough infection, the vaccines significantly reduce the likelihood of hospitalization and death. And getting vaccinated, I know, is a big decision for people, and most people who were excited for the opportunity to protect themselves and their communities have gotten vaccinated. And now there are some folks who are unsure about whether they want to get vaccinated or not. I would say if people are hesitant to get vaccinated or to have their kids vaccinated, there is a lot of good scientific evidence available, and people should inform themselves and be able to make their own decisions, but to do so using reputable websites. A couple of them are shown on the right-hand side of the slide, the cdc.gov website and the Hopkins Center for American Indian Health Resource Library, and also to speak with a provider about concerns. CHRs can actually be very important in providing information to the community as well. I think very trusted members of the community, very well respected members of the community. So making sure that you have the information that you need to be able to provide advice and guidance for community members is also really, really important. I think the other thing in addition to vaccines is that, while the Delta variant and other variants may sound scary, the same basic protective measures that we've been using all along, that we know have been successful all along, they also work against the variants. And so I think just remembering that we have tools that we can use, we have things that we can do to protect ourselves and our families and our communities. Wearing a mask remains really important, especially when in indoor and public spaces. Keeping distance is also helpful to avoid that transmission, and hand washing as well. As much as possible, if gatherings are happening, to be able to have gatherings outside and fresh air is really important. Indoor gatherings should be in well-ventilated spaces. The COVID-19 virus sort of concentrates when it's inside because there's limited circulation of air, limited volume of air in the room. So indoor settings remain very high risk for transmission of the virus. Another topic I wanted to just touch on to provide a bit of an update on today regarding booster doses. And I think people have heard about a lot of discussion in the media right now about whether COVID-19 booster shots will be needed later this year. For many vaccines, there's a reduction in protection over time following the initial vaccine series. And that's something that I think most of us are in the health field are very familiar with because we've gotten booster doses to help protect us against whooping cough or tetanus or other diseases. Kids will often get their initial series of vaccines at 2, 4, and 6 months of age, and then they'll get booster doses again when they're a year old, and then booster doses again when they're starting kindergarten. So I think we're familiar with this concept of, immunity sort of gradually declining over time. And public health experts have been carefully analyzing the scientific data for COVID-19 as well to see how long that protection will last. These are very newly available data here that suggest that protection against COVID-19 begins to gradually decrease over time. And you can see from the Pfizer COVID-19 vaccine clinical trial, overall efficacy at 6 months was 91%. Against infections and 97% against severe disease. So 6 months out, this remains an excellent vaccine. But we do start to see, at 2 months out, it's 96%, at 2 to 4 months out, it was around 90%, and 4 to 6 months out, it's about 84%. So there is some suggestion that there may be waning immunity that booster shots may be able to help with. So I mentioned that booster dose is an additional shot that's given to reinforce protection after the initial protection from the vaccine has faded, and that most of us have received booster doses for other vaccines. I want to differentiate the booster dose from what we're hearing about a third dose that has been recommended by the CDC. The third dose that has been recommended is specifically for immunocompromised individuals, a very small subset of people whose immune systems likely didn't respond well to those initial 2 doses that were given. And so a third dose is recommended for that small subset of people with weakened immune systems so that they can get up to a level of protection that is similar to what everyone else got from their 2 doses. So the vast majority of people still have a very strong response to their initial vaccine series, but that subset of people has been recommended for a third dose. A booster dose is different than a third dose. And we do, like I said, because of some suggestion about waning immunity, we do think that a booster dose will likely be needed to maximize the vaccine-induced protection and prolong the durability of the vaccine. I think it's really important just to remember the process that we go through here in the United States for authorizing vaccines and for making recommendations for vaccines. Right now, the CDC and the FDA are evaluating the available safety data and effectiveness data for the different mRNA vaccines to make sure that they actually, will confer a benefit and that vaccine booster shots can be administered safely. So if booster doses are recommended based on the fact that they're expected to be safe and efficacious, it's expected that they could be rolled out as early as this fall. Some people have asked about Johnson & Johnson booster doses because the Johnson & Johnson vaccine was introduced several months after the Pfizer and Moderna vaccines. We're still gathering data. And so that recommendation may come a little bit later. But the bottom line right now is that at this point, booster doses are not routinely recommended, but that the data are being carefully looked at to see when they may be needed. As we look towards the future of what this pandemic has in store, I think looking at the different variants that are circulating is helpful to understand what we may be up against. As I mentioned, right now in the United States, the vast majority of cases are caused by the Delta variant. You can see well over 95% of the cases now are caused by the Delta variant. And the current vaccines that we have still offer strong protection against hospitalization and death due to the Delta variant. And this is expected to be the case for any emerging variants as well. There are these new variants that have shown up in other countries, but these are not getting a foothold in the United States at this point. And vaccination is really the best way for us to prevent new variants from emerging. As we mentioned, the more the virus has a chance to replicate and spread, the more there is a chance for variants to emerge. The best way for us to stop that is through vaccination. Two other variants that have been getting some media attention that I just wanted to highlight are Delta Plus and the Lambda variants. Delta Plus has been identified in a number of different countries, including here in the United States, but it remains a relatively rare strain. And currently the other just sort of main Delta continues to dominate. Lambda is another variant that's spreading rapidly in South America. It has been detected in most states here, but as you saw from the graph I just showed, Delta is still dominating, and we're not seeing much transmission of Lambda. There are other variants that will continue to crop up and are continuing to be studied by scientists around the world. And I just will say again, that the vaccines in combination with our other strategies are really remain our best line of defense right now. And to that point, I just want to highlight what an amazing job Native American communities, IHS, and tribal health organizations have done. People have really stepped up, and Native Americans have, of all of the different racial ethnic groups across the United States, Native Americans have the highest percent of people who are fully vaccinated in the United States. And that's really thanks to tremendous efforts to people who are on the front lines on the ground, and people who are, taking that time to talk with individuals one-on-one at this point to try to help people understand the reasons that they may want to consider getting vaccinated. I think everybody on this call is a really important role that they can play in informing themselves about the vaccines, about myths about the vaccines and how to respond to those, and how thinking about just how at this point a lot of vaccination efforts are really going to come down to one-on-one conversations with friends and family and people in the community and this is a framework that I think can be really useful, especially for people who may be a little bit unsure about whether they want to get vaccinated or not, to listen to the concerns that they have with empathy, to try and understand without being judgmental, to once you understand those concerns, then help either provide information yourself to get, inform yourself with the knowledge that you need to help answer the questions and concerns, or to direct people to information from a reputable source, and help them to find their own motivation, their own reason to get vaccinated. We're all exhausted from this pandemic. We all want this to be over. And I think helping people to understand, that even if they've been sick with COVID, even if they think that they're young and healthy, we all still can take this important step to protect ourselves and our communities. And then to offer any other forms of support that may be useful by either helping to find transportation or helping to make appointments to get people vaccinated. I think we're all in a position now of wanting to do, the best that we can, whatever steps that we can take to help in this pandemic. We want to take them. So I thank you all for your time, and really thank you for all that you do for your community. Thank you.
Great. Thank you so much, Dr. Hammitt, for providing us with this information on the Delta variant, as well as the boosters that are up and coming. So thank you so much for being here with us today. And I know that I see a lot of you are already utilizing the chat and the Q&A box. We will be taking questions throughout this webinar, so please feel free to continue to put your questions in. And for those who have already submitted questions, just to let you know, we are not ignoring you. We will answer them at the end of this webinar. So we will have some time for a little bit of a Q&A session at the end. With that said, again, thank you, Dr. Hammitt. We will be moving on with our next section of today's webinar. So I would like to introduce Michelle Archuleta. She will be giving the national data update from the Indian Health Service Vaccination Task Force. Michelle Archuleta is an enrolled member of the Lone Pine Paiute Shoshone tribe with ancestry to the Oke-Owingeh. She is currently the Indian Health Service National Community Health Representative, Consultant, and Community Health Team Lead. Michelle has an extensive background in health promotion and community-based programming at the local, state, regional, and national levels. So I do have her presentation, and I'll pull it up, and then we can get started with that.
Oh, great. Just a mic check. Can you hear me, Olivia?
Yes, again.
Oh, okay. I want to say thank you so much, Dr. Hammitt. That was just phenomenal information. I especially appreciated the differentiation between the booster and that third shot. So thank you. And I know that the information shared is just spreading. I'm sorry for that metaphor, but like wildfire, across our participants here, and it's just so impactful. I want to also say thank you, Olivia, for the introduction. And I appreciate your skill and your expertise guiding us during this presentation. My role is to take this next leg and to provide a little bit of big picture information about our national CHR program. I'll bring in some information, just one slide about the Indian Health Service in terms of a cumulative look in terms of vaccination efforts. But the exciting thing is sharing this opportunity with our 3 CHR leaders who are very motivational. They're very, I would say, exceptional in the work that they do in their communities to take us into what's going on at a community perspective with COVID and vaccination. So next slide, please. Thank you. So this is Indian Health Service, our update. This is current as of September 7th. And we really do have a focus on that third dose. And you can see that in our last paragraph there. We are actually, as IHS, targeting the immune compromised individuals, as Dr. Hammitt had referenced. And so I wanted to just say thank you so much for that clarification. And currently within the Indian Health Service, that also includes patients, employees, our tribal and our community members. We've administered more than 1.5 million vaccine doses. So that we are, and this can only have happened with strong partnerships across tribes, across states and agencies. So we feel very honored to have been able to reach that many in terms of vaccine doses. We currently, as a race, we're at 59% of American Indian and Alaska Native adult patients receiving at least one dose. And we're close to, if not a little bit more than 49% having been fully vaccinated. And this comes from that link below. It's on our IHS website, and it's under the news tab on our COVID-19 information site. So next slide, please. Thank you. I like to show this because, with fact sheets and information, love the great work that Johns Hopkins is doing in terms of these graphic designs and making it so relatable to Native American communities. But these are downloadable materials from our IHS COVID-19 vaccine site around confidence materials with vaccinations. And this is just an example of 4 different types of backgrounds. We have one for mountainous regions, desert regions, central regions, so southwest regions. So feel free to go to this site, and they are customizable for you to put your own information in there. So I wanted to just make note of that. Next slide. Thank you. And next slide. Thank you. So this really is just my quick opportunity to just say how proud I am of the CHR national program. And this is a large contractual program that's really run at the tribal level. And so this is a fact sheet on both sides. They are actually housed on our ihs.gov CHR website. You can go there under About Us, and you can actually download these fact sheets. And they really are, I would say, important for CHR programs. When you have opportunities to talk about your tribe, your CHR program, these could come in handy in terms of providing information about your workforce as a CHR program, what your strategies are, what your focus areas are. It's just, and maybe some of you are really focused on those social determinants of health. So you can see the bullets down on the left-hand side. It's just an easy way to talk about your CHR program. On the right-hand side is the second fact sheet, and it really talks about being those trusted frontline public health workers, very, very equal to the health education program, your educators. We couldn't do the work without CHRs and educators out at the community level. As Dr. Hammitt did mention, you are the trusted front line. And so I wanted to just show this. And so please go to ihs.gov, CHR, About Us, and this is for you to actually download those fact sheets. Next slide, please. And then this is just a few slides that just talk about our CHR national program focus. We're very community centered. We believe in strong community partnerships. Many of our programs across tribes, our goal priority is to increase access to healthcare. And we really have a bridge to help connect that high patient population that are experiencing those high risk conditions around chronic diseases to health services. So I want to say thank you all for doing the work that you're doing out there. Next slide. Here are some bullets that give kind of an overview of outreach that happens with CHR programs. Many different types of screenings, whether it's around colorectal cancer screening in partnership with health promotion, health education, providing a community-based health education component, whether it's out in the community setting or in the home-based setting, providing specialized information and referral, and really participating at outreach health fairs. These are different types of outreach. Next slide, please. I really love this slide in terms of the CHR program really has two best practices that we focus intently on, and that is the Family Spirit Program in partnership with Johns Hopkins. And many of you have been trained through this program, your home visitors, working with young parents. And then we have an exciting equal program to Family Spirit called Health Coaching Initiative, where we're targeting CHRs and health educators. And it's a 2-year pilot where we're going to take participants through the tools of health coaching. And so they are going to be able to integrate those new tools into their existing programs or learn how to integrate the health coach component into their healthcare system. So that is very, very exciting for the CHRs and our health educators. Next slide. This is just a quick slide that really talks about a team-based approach to healthcare that includes CHRs with our healthcare teams. And you all know what that involves in terms of, I mentioned the screenings, but your community projects that are happening. And I would say, especially around COVID-19, with community preventative education that's happening across tribes. You are so instrumental in helping to get that information out to community members around vaccination, supporting contact tracing, helping to stand up flu shot clinics. So there's a vital role that CHRs and educators play, not only around the health education component. You're so instrumental around HIV and AIDS, tobacco cessation, health coaching component. We're looking at a fitness certification for CHRs, home environmental checks. So I really want to just say, that health education piece is very, very important. But I will also say teamwork. And I always hear this, teamwork makes the dream work. And that is so true in terms of, I really say, what impacts patient care. And so continue to reach out across the healthcare system at your site. You are a part of that healthcare team. Next slide. And this just really is, quick statements about how you make a difference. And you are enhancing clinical and patient communication. You're enhancing patient understanding of their health, of what it means to really understand and work through a chronic disease, and I would say embrace it in a positive way. Enhancing integration. That is really, sometimes it really is up to you as a CHR to step into that clinical team, in the way that you do. And community engagement is a real big difference that you make. And I'm going to really say CHRs are so instrumental in reducing barriers around access to follow-up and to continuity of care. And you do that with your care coordination and your case management approaches. So thank you. Next slide. A little bit of information about if you wanted to contact me, but next slide. And now we're going to move into the exciting part of the presentation, besides Dr. Hammitt's information. But this is an opportunity now for us to bring on our 3 CHR leaders. And they are, I'm just going to name them, Antoinette Bird, and she is with, oh my gosh, I'm going to mispronounce the tribe, Pueblo of Cochiti. And then we have Elaine Ziegler, and she represents the Cocopah tribe in Arizona. And we have Miss Lynette Walker, who represents the Ho-Chunk tribe as the CHR program supervisor. And so what I'd like to do at this time, just tell you what's going to happen with this panel. We have some prepared questions, and that's going to be my role, is to ask the questions to our panel. And they have the opportunity to provide the response, and then I'll invite others on the panel if they would like to share additional information. But before I do that, I also want to just say they were chosen and identified through others as having key perceptions, key thoughts, key experiences in the field around COVID, and whether that meant participating within a healthcare environment in partnership, or going solo with CHR-related activities and strategies to support COVID. So we are very excited to hear their experiences and their thoughts and their learnings across the field. And so with that, I would like to give each one, we'll start with Antoinette, and then we'll go to Lynette, and then we'll go to Elaine. But if you could just share a little bit about yourself to the participants, and we will then move into our questions. So Antoinette.
Hi, good afternoon, everybody. My name is Antoinette Bird, and I am from the Pueblo of Cochiti in New Mexico. And I have been a community health representative for the last 18 years. And I have recently become the health programs director here in Cochiti, Pueblo. I have other programs, that I oversee, which is the CHR program, the public health nurse, our dental program, and we also take care of our health education portion of, for our community. And so that's where I am from and who I am.
Thank you, Antoinette. Lynette.
Good afternoon, everybody. My name is Lynette Walker. I come from the Ho-Chunk Nation. I'm Bear Clan member. Currently, I'm in the position of a CHR program supervisor, and I oversee 4 staff in a service area that covers about 14 counties in Wisconsin and 1 in Minnesota. My background is in leadership. My bachelor's is in integrative leadership, and my master's work is in community and organizational leadership. And so I come from the background of being a leader in community, and that's really how I approach the CHR program that I oversee. I do not have the clinicals, but there are plenty of other people that do. And so just working together with everybody has been a good experience for me so far. Thank you.
Thank you, Lynette. And Elaine.
Hi, my name is Elaine Ziegler. I work with the Cocopah Indian tribe in the very southwest corner of Arizona. If you can picture a map of the United States, we're right at that corner where Arizona and California meet, right next to like Gulf of Baja. So we're really south of just about everything. Really hot right now. We're already at 90 degrees, and it's only going to get hotter, and we're through the summer. So we're hopefully heading into the cool weather soon. I am one of the 3 CHRs at Cocopah. My focus is on health promotion, especially the COVID-19 pandemic, but then just other health promotion. I do have a master's of public health that has been, I just got a note and it's very hard to hear me. Let me see if I can turn up the volume. Hold on, give me just a second. I have everything set as high as it can. I think part of it is the AC is going in the background, and I apologize for that, and I can't turn it off. We're in the building and it's everyone's AC. So I'll just talk loud. Like I was saying, I'm the CHR for health promotion for Cocopah, and very excited to be here.
Great. Oh, thank you, Elaine. Don't worry about the sound, but
Okay.
yeah, it's all good. Okay, so now, so as I said, this is a panel, and I want to thank our panel participants for your sharing a little bit about yourself to our to the webinar folks. So I'm going to go ahead, and this is a question for all participants. Okay, I mean you as panel participants. Could you tell us, has COVID-19 impacted your program? And if so, can you please explain how? So I'll say that one more time. How has COVID-19 impacted your program? And if so, how? And we'll start with Antoinette.
I want to say, and I'm going to say, yes, COVID-19 has had a huge impact on our programs here in Coach T. Pueblo. We are used to having monthly activities for our community members with health education. You know, every month we try and provide a different type of education for, you know, various different types of topics. So we're used to having those gatherings, and, you know, with COVID last year, we had to shut down everything. And so that has really changed, you know, getting the information to our community members, and then also with the interaction. So it's been really, really hard. And we're still not providing those types of events for our community. So it's been a lot. So, you know, we've had to turn our attention to something that we knew nothing about. And so we had to turn all of our attentions to get onto many different webinars, many different types of conference calls, reading up on, you know, all kinds of information that we, like I said, we didn't know anything about. So we, it's been tough, but we're hanging in there.
Good. Okay. Thank you, Antoinette. Lynette, how has COVID impacted your program?
So when I got my position as a CHR supervisor, it was at the tail end of 2019, and right in 2020, then that's when COVID kind of hit. And some people are saying that, you know, it's a little bit before then. So right around the time when I started this new position, and so there was nothing to build off of. And so I really had to kind of like do some research and things like that. And so the program that we started building was during a pandemic. And at first, my first thought was, how am I going to do this? You know, it's a pandemic. How am I going to, you know, like, how am I going to get a fair shake? You know, something like that. But it's kind of really been mind changing for me to look at this in a very different manner and say, this is the perfect time to build a program, because we're on the cutting edge of a lot of new things that are happening in our communities. Not all good, not all bad, but we're able to build a program that includes supports for advanced care directives, right? Because we're dealing with so much loss. People don't really know how to grab onto that or grasp what's happening. And so we try to put those supports into our program. And so that has really changed compared to what the program used to look like prior to me being here. And also the health and wellness coaching piece. You know, we have a foundation with the health and wellness coach skills that we can get out there and we can talk with the people, whether it be virtual or in person, you know, at the market, at the gas station. And there we are, just, you know, having these conversations with them. And if they need further assistance, they can, you know, go ahead and contact us. So it's really building a program as things are happening. And so it's been a very interesting task, to say the least. Thank you.
You're welcome. Thank you, Lynette. Elaine.
Well, I joined COCOPA in the middle of the pandemic, so I'm not exactly sure what they were doing beforehand. I know that there is a lot more one-on-ones, visiting houses, really out in the community, and so it's been twofold, having to learn what my position is, and we're all three CHRs are very, very new to COCOPA, so we've all been kind of learning together, and then having to go out to that community. We were lucky that we had a lot of other groups and departments that were very, very willing to help us out and provide that support and kind of say, oh no, you guys are doing this and here's how we're doing it now. And then we've really turned to using social media to getting a lot of messaging across, and we're posting on Facebook quite a bit with different events, information on COVID, on the different vaccines, when we're going to have vaccine clinics, and then just other health information, diabetes. We're trying to do some cooking demos that we're posting on Facebook. So that's been an interesting experience, definitely turning to the social media.
Very good. So I'm just going to recap. So what I've heard from all three of you is typically your health education, your health information approaches really drastically changed when the COVID hit. It's really interesting to hear that you were all, not all, sorry, but Elaine and Lynette, you were learning how to build a program during the pandemic. And you guys saw that as an opportunity. And so COCOPA is looking at social media really heavily and marketing and promoting what you do from a health component piece. And with Lynette, you've moved into this advanced care directive component and the integration of health and wellness coaching. So with your programming. So I wanted to recap that because I thought that's really interesting in terms of the change. I'm going to go with Lynette. So you have our next question. And so Lynette, what has worked in your community or proven effective in addressing vaccine hesitancy?
Two things come to mind. The first thing, I was asked to be a part of a vaccine hesitancy team. And so that's one of the things that we devote some of our time during the week to, is trying to find out, what our strategy is going to be for addressing the hesitancy. And then finding, Dr. Hammitt had talked about that too. She kind of emphasized that a little bit, was the one-on-one conversations that you have with your people out in community. And can we really make them feel better with one conversation? Maybe not, but if we talk about our stories with one another and share our stories about what has happened to us, to our families, that seems to really go a long way. So that particular part about sharing stories with people and just sitting side by side with them and listening to them and letting them do the talking, which is kind of like a foundational piece for health and wellness coaching. And so that's why it really fits with our program, that we can just sit there and let them take the lead and let them say what they need to say about what they're going through, and not force feed them anything about what's happening to them. Just let them be. Thank you.
You're welcome. Thank you, Lynette. Elaine and Antoinette, would you like to add anything? Oh, Antoinette.
Yeah, I would like to add to that. I would like to say that here in Coach T. Pueblo, education is what is the key, and also listening to their concerns and then being able to talk to them at a level that they understand. Because a lot of our community members rely heavily on what, our education is to them. They know that we can, if they can go to a doctor and they don't understand, what they're saying, we're there as part of for translation. And part of translation is bringing down those words that they don't understand to bring it down to their level so they have a full understanding. It might be, a situation that they may relate to, that we have to think of at that moment, to be able, so they have something to relate to. So educating our community and educating ourselves as health providers, I think our communities really, really depend on that for us. So I think education is a very, effective thing in the community, and trust as well.
Mm-hmm. Yes. I think you're so right with that translation piece, in terms of the role of the CHR. Thank you, Antoinette. Elaine, did you want to have anything to add, or?
Yeah, I think one of the things that we really focused on was talking with some of the elders who got the vaccine very early on, having them share their stories, talking with some of tribal leadership, having them share their stories. Really, it's not just THMP, which is the Tribal Health Wellness Program, which is what the CHRs fall under. Not just us saying, go out and do this. It's here are your elders, here are your respected individuals going and saying, yes, this is something we need to do. And then like everyone else said, is just listening to the people who have the questions and sitting down and talking with them and letting them talk about why they don't want to get it, and then seeing if you can talk around it and kind of convince them. And it may not be that one conversation. It's going to take a couple.
Nice. Thank you all for sharing what's worked in your community as you have are in the process of addressing vaccine hesitancy. I'm just going to say and recap: education, listening, translation as kind of the biggies. So Elaine, I'm going to go to you. What have you noticed in terms of vaccine uptake or acceptance with different age groups in your community?
Well, I know that a lot of our elders, that's who we started with with the different tiers. A lot of the elders that I spoke to were very, very interested in getting the vaccine, or very excited when we started going around and saying, hey, are you interested? Can we help you getting any sort of documentation, setting up appointments? So that was really nice. And then right now, it seems to be some of the younger age groups who are healthy and maybe don't quite understand how the vaccines work. And then it's just, we're working with them to kind of get them on board and make it kind of the hip thing to do. Kind of trying to do the trendsetters. So I think, right now it's a lot of the younger generation that we're trying to talk through, and they haven't been here as long, and so they don't understand why it's important.
Okay. Do Lynette and Antoinette, would you like to add anything to that question?
One of the things that I noticed out here in community, so the loss that we experienced because of COVID and all the different things that kind of come into play with one's own health. One of the things I've been seeing is that some of these people that have been losing family members then become the community advocates. And so they are the ones out there talking to other families who may or may not be vaccinated yet and promoting, get your shots, get your vaccinations. This is why I lost this person. You don't want to lose your family members. And so they really become then the community advocates out there. And it's really kind of neat no, it's not neat that we are losing people, but we are finding a way to really strengthen one another at a really tough time, at a really difficult time. And seeing this from other family members in their communities, really, it gives me hope.
Nice, Lynette. Thank you. Antoinette, anything to add that's different?
No, we're kind of seeing the same trend with Elaine. So, I mean, I don't have anything to say right now.
I will say, Elaine, I bet you can tap into that social media with the young people.
Yeah, we need to do some more COVID related flyers. We did a lot of videos right when everything came out. So I think just kind of reminding everybody and just making it a little bit more flashy.
Yeah.
All of our flyers and stuff are kind of sedate, and I think we need maybe not quite confetti, but like virtual confetti, like balloons, things, a little more flashy to try and grab their attention.
Good. I will have to give the Hopi CHR program a big shout out. They are just fabulous with using social media, Facebook, to really increase vaccine acceptance and just community preventive messaging around COVID. So for those on the call, check them out. Antoinette, how are CHRs facilitating access to vaccines for youth who are eligible?
Okay, so here with Coach T. Pueblo and our service unit, we are working very closely with them, and we have vaccination clinics that we were providing kind of every week. So when it came time to the youth who were eligible to get vaccinated, we worked very closely with them on who the kids were in within what age range. And so when it came time for that, we contacted, because we already earlier on, we gathered information from our community members as far as like phone numbers for us to be able to reach our, individual community members. We have parents' numbers now. And so it's easier for us to contact mom or dad or guardian of the child who is eligible to get the vaccine. So like I said, we're working really closely with Santa Fe Service Unit, and then also contacting parents and guardians to be able to get their child up to a vaccine clinic wherever it may be. So we have, been working really closely that way. And if they can't make it to that vaccine clinic, we also have another sister community who offered vaccines to us as a community to be able to go to their clinic and receive the vaccine. So if it, for whatever reason, didn't work for the child to get up to the vaccine clinic, then we referred them to the other, sister clinic where they were able to get their vaccine. So a lot of our youth were vaccinated fairly quickly as well. So, that's kind of how we're able to facilitate the access for the vaccine to our community youth.
So it sounds like, yeah, you guys really concentrated on a direct one-on-one outreach component,
Yes.
accessing that phone number, making that call, right?
Yeah. And so, like I said, we called every single individual, and some families had 2 or 3 children who were eligible within that age group. So we all set them up on one day, okay, you take your 3 kids and you go up to the vaccine clinic. And so we didn't have too many parents say, no, I'm not getting my children vaccinated. They were, happy that we were the ones able to give them a date and a time for their child. So,
okay, great. How about Lynette and Elaine? Do you have anything to add?
Most of our vaccination clinics and scheduling and everything was through the IHS facility, but COCOPA definitely provided a lot of transport, and we're still transporting individuals who want to go get the vaccine. And that was probably our biggest contribution, was doing the transports and then talking with the community saying, hey, the vaccine's here, can we help you set up an appointment? And then really just partnering with IHS, our IHS facility has done a wonderful job of rolling out the vaccine. They've done extended hours, they've done weekends, they've done vaccine clinics on the different reservations. So they're trying to get out there and we're just supporting them.
Okay, good. I'm going to move to my next question. Let's see, Lynette. How are leaders and public health representatives across your region making a safe space to hear questions or concerns from community members?
So the director of health here has conducted a number of town halls, virtual town halls, and you're allowed to submit your questions ahead of time so they can prepare and get the information for you. We also have an epidemiologist who contributes a lot of information on the stats of the nation and the vaccines. And so that information is readily available on the website as well. But I think the I think people are not taking advantage so much of the town halls as they can, whether it's they cannot access or do not know how to access. But that has always been something over the months since the vaccines have come into play, where people are allowed to go ahead and speak at these town halls. So that has been really interesting as well.
Okay. I'm going to move to the next question. I'm going to go to Elaine. Has your program or tribe mandated the vaccine for employees? And if so, have there been any resistance to the mandate?
As of yet, COCOPA has not required the vaccine for employees. There is some discussion going on with the tribal administration, tribal council, regarding if they want to mandate vaccines. But so far, they have not mandated it. They have mandated mask requirements, but no vaccine requirements as of this moment.
Okay. And just to kind of keep with the time, I want to kind of move into another question. Antoinette, given emerging concerns with the Delta variant, has anything about your approach changed? So now that what have you learned with the Delta variant and its concerns? Have you changed anything as a program in terms of approaching vaccination?
So our community is still closed to non-tribal members at this time, and nobody other than tribal community members have access to come in and out of the community. So we're still closed. We currently are not having any kind of large gatherings, even if it's, we've put on hold our traditional activities. We've held, funerals, kept them small, so with our tribal leadership, it's just still recommended and very highly encouraged that we do not gather or have these large gatherings in order, to keep the spread from happening. Although, we are getting some positives here in the Pueblo, we're really containing those to their own homes or, to the single person who is positive. So we're still, working on getting people vaccinated. We're gonna start a COVID-19 newsletter with updates that are gonna be given out to the community monthly, because that's what we heard is wanted. So we're going to start that here this month in September.
Okay. We have 15 minutes, so I want to go through 4 more questions. Let me see, Lynette, as the pandemic evolves, what are your best practices and tips for keeping community members informed with the latest guidance?
Well, the visiting, again, the door-to-door visiting, sometimes I get on my bike and literally pedal around the community. And if I see people out there, it's just a hello, hey, and just have a little conversation, move on to the next person. Because a lot of people are not comfortable with all the technology. A lot of people are coming on board with it. But I think that's one of the things, is just getting out there by the people, masked up, of course, and, just having those conversations. That's one of the things. And then using, you mentioned it earlier with the family spirit, and that particular program is really awesome because it's so versatile. And you can grab the tools from there and you can use that out there in community, how you can talk to them and make them comfortable and get their feedback too. And I think that's one of the things that we keep on going. And I've said earlier, the health and wellness coaching techniques and models have really come into play with how we are talking to people out here in community. So those are just, the things that we are continuing to do.
Okay, thank you. Elaine, this goes to you now. And so not to put you on the spot from a personal perspective, but how do you acknowledge your own hesitancy on a personal and or professional level? With vaccine hesitancy. How do you reconcile that if you haven't?
So this is my personal opinion for myself. I had very, very little hesitancy getting the vaccine. As soon as we found out we could, it's like, I want to be first in line. I have a very strong biochemistry molecular background, so I drew a lot on that for myself to when I was making my decision if I wanted to get the vaccine. And then I drew on it when I was talking with both people, both the CHRs and colleagues, but then also when I was talking with the community. And I think it was Antoinette who said it's like making the vaccine at the level that they understand. So I knew the science behind it, so I was able to almost dumb it down and convert it into language that does make more sense to the general population.
Okay. I'm just going to ask Antoinette or Lynette, do you have any thoughts on that? Because that'll be our last question as a panel. Any personal or professional hesitancy?
When I think about this question, I think about the messages that we get. You talked about mandates earlier, and the Ho-Chunk Nation has not mandated that you get your vaccination yet. So I work in the health department, and we had a discussion about this, and somebody had asked about it. And you're working in the health department, yet I don't know, how can you promote it? The practice and preaching type thing. And I think, oh my gosh, how can we be? And again, it's a personal choice. I mean, that personal and professional ideal kind of like clashes. And I'm like, how do you do that? I mean, for me, my own personal self, I didn't hesitate. I wanted the vaccine. I wanted to see, if I could get it, what it does to me, and then other people can see, hey, she's okay, she's managing. And I think because I got it, it felt, when I did get COVID, it felt like it wasn't as bad for me. And maybe it was just the timing of everything. And so other people seen that, and I would talk to other people. And so the hesitancy for me, for myself, really wasn't there. Now you're talking about my grandchildren becoming vaccinated, and I'm kind of like, I'm not sure yet. And so I think, like Elaine was saying, the information of the science of it, and really helping people, with the health literacy pieces of this and what this means could become really valuable to us in being able to promote this.
Nice, very nice. Antoinette, anything to share?
No, I'm just kind of in the same boat as, I didn't have any hesitancy when it did come to the vaccine. I was ready for it. I want to be healthy to be able to be here for my community, because we need to take care of ourselves first before we can also take care of our community. So when it was time to get vaccinated, I was ready.
Good. Okay, well, I want to just say thank you to Elaine, to Lynette, and to Antoinette for sharing your thoughts, your experiences, and your personal perceptions around this topic. And I want to pass it back on to Olivia, where she's going to take it to more of the participant Q&A session. So back to you, Olivia.
Great, thank you, Michelle. And thanks again, you all, for joining the panel discussion. We're going to take this last 10 minutes to get some of the questions answered from the participants. So we'll start with Dr. Hammitt. Just curious, does this health team think that we will have to have shots from year to year to survive? I received both my Moderna shots, but not eligible for the booster shot until October. Will this be a yearly thing for people?
Thanks. That's a question I think is on a lot of people's minds right now. And the real answer is that we're still learning about this virus and about this pandemic. We have many examples in medicine where, we get vaccinated, very early in life, and that protection lasts a lifetime for something like measles. We have other examples where, for example, something like tetanus, where we have to get periodic boosters every, 5 to 10 years. And yet other examples where something like influenza changes so much that, we're getting vaccines yearly. And I don't think we know exactly where we're going to fall with this virus, but I suspect that, we're going to definitely evaluate the data as they're coming in. I think that, the indication is that we can expect to require booster doses to prolong immunity. Whether that's just going to be, a booster dose and then we're good for a little while, or whether we'll need to get more frequent booster doses, I think remains to be determined.
Okay, I'm going to try to add on a follow-up just because it's so close. So I know that they were doing like trials on the booster shot. So is there, or can you add some clarification on when the boosters will be available to the larger population?
Yeah, so that is something that's being studied right now. And as soon as those data are available, right now, FDA is already gathering data on booster doses, and they're also looking at experiences in terms of what's happened in other countries with vaccines and how the effectiveness has changed over time. So FDA will look at those data. They'll look at the data from the clinical trials where booster doses have been given to assess the immune response, the safety of those booster doses, and then whether they actually confer additional protection or not. And so when those data are available, we expect that, we know that FDA have already received some of those data and are reviewing them right now, and we'll be meeting later this month. And they will be the ones that, will determine whether or not sufficient data are currently available in order to make those recommendations. So it may be, as early as this fall that we have a recommendation coming out for booster doses.
Great, thank you.
Mhm.
This is for the CHR team. So are there any CHR working from like remote locations, like providing home visiting, telehealth, health education from like a remote standing? Have any of you used that type of platform?
So this is Lynette. Again, I'm going to mention Family Spirit. That is home visiting program, and that is what we do virtually. We can do that with parents as well. And the health and wellness coaching, we can also do virtually from remote areas, as long as the patient or the client has, the access to us that way.
I want to answer that too. Here in Coach T. Pueblo, we don't have very good internet service. So the way we are reaching out to our elderly and our community members are all by phone, but our health department, our CHRs, our public health nurse, our special diabetes program workers are all here at the office working. We, through the whole pandemic, we did not have a day off. So we were here sometimes, 8 o'clock in the morning to sometimes 9 o'clock at night. But we did all of our like home visits and everything through phone because, like I said, we don't have the internet access here.
Great, thank you for that information. Dr. Hammitt, are there other treatments for COVID-19 in development or clinical trials other than the vaccines?
Thank you. That's a great question. And there are a number of different treatments that are being studied right now. I think people are probably familiar with the monoclonal antibodies that are being used, and there are a number of different formulations of monoclonal antibodies. That's a mainstay of treatment, but there are other antiviral therapies that are being used in addition to steroids being, particularly for people who are hospitalized or have more severe disease. In addition, there are other clinical trials that are ongoing looking at different antivirals. So I think that there is promise that there will be treatments. Ideally, because COVID-19 can cause sort of long-term sequelae, it's better if we can prevent the infection from, setting in altogether rather than to treat the infection. We always want to prevent rather than treat, but it's good when we need to that we have those treatment options available.
Thank you. So going back to the CHR team, is there anything state, local governments, and school boards can take away from tribal nation governments?
Is there any more for that question? I'm not sure if I quite understand what they're asking.
I feel like just noticing or seeing the different approaches that the local communities are taking to address COVID-19? Like, is there
Also, key
anything you would
takeaway is
suggest?
not like
Mhm.
take it from
Yeah, just any practices that they could take away from tribal communities.
I guess here in Coach T. Pueblo, as far as school, our tribal leadership has, put out to the community that they are not allowing our youth who are not vaccinated able to attend school. So they have to do virtual learning. And like I said, with the internet service, us not having good internet service, it's kind of hard. So, we have to do the best that we can for our children and for our community members, to keep them safe. And so I think our tribal leaders who are trying to protect our people have to make those decisions. And then, we're lucky if our community members are gonna, listen and do what's being asked of us.
Great, thanks. I know that was kind of a loaded question and it's different for each part of the country. I'll go back to Dr. Hammitt. What is the role of autoimmune response after the COVID-19 vaccination? Have there been any instances of vaccine-enhanced disease?
Thanks, Olivia. There are no described instances of vaccine-enhanced disease, which was a really important thing to understand from early on. And fortunately, we've got lots of clinical trial data at this point, as well as hundreds of millions of doses that have been given around the world. And there's no instance of, or no evidence of vaccine enhanced disease at all, which is really reassuring and really important, I think, for people to have confidence in that. We do know that COVID-19, the virus itself, can cause some autoimmunity, and that can be one of sort of the long-term things that we can see, is that there can be that from the virus itself, but there's no evidence that the vaccine actually causes any autoimmune findings. And I'm not sure if the person asking the question may be aware of the clinical trials that are ongoing right now. We know that people who have autoimmune disease are at higher risk of more severe COVID if they get infected. And so it's important that vaccines actually are demonstrated to work well in those groups as well. So NIH is specifically looking at giving vaccines to and additional doses of vaccines to people who have autoimmune diseases, and even potentially having them pause on their treatments, some of which are immunosuppressive. So when they get the vaccine, to pause on their treatments so that they can get a better response to the vaccine, and hopefully, then have better protection, because getting infected actually is, can cause flare-ups with autoimmune disease. So.
Great, thank you so much, Dr. Hammitt. Okay, so we are out of time. We just wanted to give you a little bit time and just to remind you that there is an exit survey for this webinar. I know there were some questions that have not been answered throughout this panel or this question portion, but we will be sending out a recording to this webinar and we will follow up with any unanswered questions. So please feel free to put any questions in there if you have any last minute thoughts. Thank you so much, Dr. Hammitt, Michelle, Elaine, Lynette, and Antoinette. Thank you so much for your expertise and for doing such great work in the communities. We really appreciate it and are thankful for all that you have done, as well as providing great information during this webinar, for answering questions. I feel like the line can go, or the list can go on, for thanking you on everything that you guys have done. But again, we appreciate all of you who have joined us today, taking the time out of your busy day schedules to listen in on this information, and we look forward to seeing you back later on. Thank you again for everything, everyone. Have a good evening.